Good morning, everyone. Thank you for attending a Sunday morning course after a Saturday night. My course is called Dr. Know Navigating My Toughest Case this year. So, as surgeons, we all know that it's important to understand not only the possible outcomes of a tough case, but also to be able to understand what steps lead to the success to a tough case. I'm joined in this IC by a panel of extremely talented surgeons. I am very thankful for them to be present here today. And this course not only speaks about the surgeries that they go on in daily life, but also importantly to discusses as to step by step what goes into the making of a very successful story after a very complicated beginning. So I'd like to introduce my speakers. Uh, The first speaker is Dr. Samresh Srivastav. He is the leading cataract and refractive surgeon and serving director at Raghudeep Eye Hospital right here in his hometown in Jaipur. His expertise includes advanced cataract and refractive surgeries. He has a strong research focus on optics and his surgical work has great academic depth as well. He is a frequent invited speaker all over the world, including ASCRS, CSCRS and APACRS. And he has received several international awards, including the Grand Prize at ASCRS, to which I was witness. He has authored over 20 peer-reviewed publications and contributes to academic literature and now dabbling with artificial intelligence at great depth. Welcome, sir. Please, I would like you to introduce your talk.
Thank you, Shivani. Thank you for inviting me for this course. I'm going to present a case which is, it's navigating tough cases. So I'm going to show two cases, but I'm going to show the interesting case first. I call this thinking out of the box because this patient turned up to me in my clinic with a history of trauma. So he's a repair mechanic, and when he was grinding something, this young boy had something going into his eye, for which primary repair was done elsewhere. After the primary repair, which you can see the sutures, there was a corneal scleral rupture query because he had no papers. This was the situation. The pressures were high. There was a big cystic bleb over here, and there was lens matter in the timber. So I went ahead. I did a cyst excision. It turned out to be an intrascleral pocket, which I excised. And I closed the eye. So this was the bleb that I removed. But after I removed the bleb, the patient settled down with the scleral patch graft, but the pressure never went up. So when I kept on looking at the patient's eye, the IOP was never going above 2 or 3. And I found out that there's a fistula which is leaking. Now you can see when I'm staining it with dye that there is a fistula and it's all constantly leaking. I did all I could possibly with using medicines trying to see if this fistula could go away. But this thing would not budge, and the patient's eye was going into hypotony and the patient's choroidals has started to appear. So I decided to take up the patient into the OR and see what I could do about it, because I was at my wit's end because I could not see the fistula in the OR, so I didn't know what to do about it. Initially, I thought I'm going to put a glue and BCL, which I did, but it did not work. Now you can see the scleral patch graft here, and if you can see that there is a mild leak somewhere over here, you'll be able to see as I compress. But then I decided that enough is enough, I need to close this eye. So I went back into thinking out of the box. So this is my OT technician who's holding a torch with a blue light, a blue filter, which was lying in my daughter's project box. And he's shown the blue light, and I put in this patient's eye, I put the dye. And the moment I put fluorescein and turned to blue light, lo and behold, I could see where the leak is coming from. So now in the OT, I have the main microscope off. The fistula is visible. It's a micro fistula. It's very difficult to pick up this fistula. Otherwise, even on slit lamp, it was difficult to capture, let alone finding out what to do how to see it in the OR. And there you can see the leak that's showing out very nicely. Now the question is, what am I to do with this picture of this fistula? Initially, I thought I'm going to put a small conjunctival patch graft on this and then leave it. But even if that graft is not going to hold initially, or if there is the fistula finds a track through that, it will be a covered fistula leaking from the other end. So I decided that I'm going to try and suture it. So again, I'm just showing you where the leak is happening. So I decided that once I go into main light, I won't be able to see it. So I'll mark it with a pen, which is what I'm doing. I'm trying to dry up the area and trying to mark the area, because once I lose it, I'm not going to see it again. And then eventually, I did a image guided, fluorescein guided suturing of the fistula. So I passed the fistula. The moment you can see the leak happening over there, and that's the fistula over there. And I passed the suture straight through the fistula out. And I could do it because of the additional light source which my assistant was holding in, and it was his idea that let's try this. Once I passed the suture, the eye settled down, and I obviously did cover it with the glue and BCL at the end. So I'm just showing that I could pass the suture through and cover it with glue and BCL finally, and the leak finally went away. Trick with BCL and glue is you always need to inject BSS while you're putting the BCL inside, so that all the area that is irregular because of the glue settles down. The problem is now the patient has an IOP of 40, because because that was working like a filter and now it's gone. So that's one story to it, but it made for a very interesting case to present, so I thought I'll show that. And this is my second case. Again, interesting cases generally come out of traumas, and so there we go. So this is again a patient, a car mechanic, who came with a spanner that had hit his eye, and patient was light perception accurate. This is how the cataract is. You can see there is a zonular loss, and there is also a loss of iris tissue. It's not a mobile lens, because if the lens is wobbly and mobile, you realize you need to take out the entire lens. But because the lens itself was stable, we decided that we are going to stabilize the capsular bag after doing a rhexis and try to fix this capsular bag onto the scleral surface so that we can maintain the compartmentalization between the anterior and the posterior chamber. The cataract is a soft, mature cataract, so we didn't even make the main incision, and using these MST hooks, once we stabilized the bag, we cleared off the capsular bag. I had already dissected out a small scleral flap in the idea that I'm going to be possibly fixating a CONE element or a CTR in the eye, and there we go. We are fixing we are doing a scleral fixation using a CTR with the CONE ring, and I'm using a Gore-Tex suture. One thing about Gore-Tex is it's easy because it's easily visible, and it's easy to manipulate over a thinner suture. We use DMAC forceps to externalize. Rather than doing a railroading technique, I cut off the needles, and once I put the suture inside, I use a DMAC forceps to a 25 gauge tab incision, take this suture out. And here I'm trying to make sure that the eyelet of the CONE ring is above the rhexis and not underneath it, because if it's underneath, it will not be easy to do it. And then you titrate your suturing. The second good thing about Gore-Tex is that you can titrate your suture to make sure your bag is centralized, and take all your time to do this. This was followed by an in-the-bag IOL delivery. And notice up until now, there has been absolutely no vitreous disturbance, and the anterior and posterior compartmentalizations have been maintained. There was vitreous hemorrhage, so we made sure now the retinal surgeon goes down and clears off whatever vitreous hemorrhage was there, and to look for breaks to make sure that everything is cleared off. And this is how the patient looks post-operatively, and that's how the CONE looks. It's a well-centered lens, beautifully sitting in the capsular bag. Unfortunately, the patient has a macular scar, and the patient will not improve beyond 660. But now the problem is, the patient is young and wanted to get married, but got rejected once because the shine of the IOL was happening when the family met. So I decided that now, just for cosmetic reasons, after 3 months of the primary surgery and making sure the retina was not deteriorating, we did a single pass 4-throw pupilloplasty. I'm not going to go into details of this, but I'll just show you that we did the first throw, and this is how we were able to close it. But there was the pupil was not small enough and would still shine through, so I closed it a little further so as to create about a 3 millimeter pupil, just enough to keep a watch on the retina also, and cosmetically also to make sure that the IOL does not shine when you're looking at the patient's face. So what started as this ended as this. So in summary, keep things handy. I like, more than the railroading technique over the Prolene, I like the idea of using DMAC forceps, because DMAC forceps have much more use than DMAC. You could try it out, and more importantly, think out of the box, try to maintain compartmentalization. And if these cases do turn up, please record. Thank you. You're going next? You are introducing. Okay.
Thank you, sir. That was a very insightful video and a very interesting presentation. I would like to next introduce my mentor, Dr. Kumar Doctor. Everybody knows that he has won the CS Reshmi Award last year, to which he got the award this year. So congratulations, sir. And it's not only an achievement this this time, but every year, every time I see him producing videos and recording our cases and making something completely innovative and different out of it. Innovation is his second name because he has also innovated two new instruments which will be coming out, one of them already in the market, the other one we are still processing and patenting. So every day it's like a learning experience, not only in the OR but also in the OPD with him, with his innovations. And today he'll be discussing cases to show how his innovative mind works in the OR as well, to make sure that the outcome of every case is perfect and we get a beautiful video out of it as well. Thank you, sir. Can you please take over?
Good morning. 1 second. Okay. So I'll just show one case, and this can happen to anybody. But what's important to learn here is how to get out of a problem which is created by you itself, right? So purely iatrogenic. So when you see this case, it's a straightforward, simple, reasonably well dilated pupil, soft cataract. But if the patient has a prostate history, will you use a ring? Now, if you see this, it's almost, my video is 5.5 millimeter. And if you see the pupil is slightly smaller than 5.5, so it must be about 5.2 or something like that. And it's a soft cataract. So you will wonder, why do you need to use a ring? It's a straightforward case. Just go ahead and do it like normal. So I'll just show you what happens, right? So we're going ahead, doing it like a normal case, really nothing much to worry. I normally like to make the side port, and once the side port, I use epitrate or adrenaline. So what I'm doing here is actually putting viscoat on the pupil, okay? And the center part will be normal Helon, or what I have no financial interest. But normally what happens is we feel psychologically secure that the viscoat will sit on the pupil margin and the pupil will not flutter or it will not move, right? So I'm putting viscoat on the pupil and the rest of it may be simple Helon. And it really works quite well in many cases. You will realize I'm putting it all around on the pupil and making it sure that it remains reasonably like that, okay? And then I'm going ahead, now you can see the pupil is about 5.2 and the virion is 5.5. Going ahead, and I almost like to do my rhexis with the forceps itself, right? So just going ahead and going parallel to that and then doing the rhexis. So everything is good, I'm fine, I'm happy. There's nothing really much to worry here. But once you've done you can do staining if you really need to or you want to. Now finishing my rhexis, then go ahead and do your hydro procedure, so that's fine. And then go ahead and start your phacoemulsification, right? So I've started phaco. You can see it's a soft cataract and it's reasonably well dilated. I mean, I don't think you need to worry about this, but you can see now sometimes the pupil starts coming down. Again, you can use epitrate or whatever you want to use to dilate. I always use this sharp tip chopper, which was designed by me in the 90s. Very, very long time back. It has multiple lens. It's no financial interest. It's made by Epsilon. It has 3 variables, but it's sharp tip, and you will never hit the posterior capsule because it is sharp. So remember that. So now you can see the pupil is coming down. And in olden times, if you remember, when we had a system, when I started phacoemulsification, normal trend was if the pupil is down, you reduce your flow rate. Long time back. This must be 20 years back. But in new technologies, this is signature now, I'm using Veritas. You don't need to reduce your flow rate, which is a known fact. Nowadays, we don't adjust flow rate even if the pupil comes down. So the fluidics bottom line is so good that you really don't need to adjust. So here you can see everything is fine, nothing much to worry. I'm rotating, nucleus is rotating well, so hydro has happened well. Pupil is small, which we can see. And you can see that pupil is trying to come out of the side pot. It's also trying to come out of the main incision, right? So obviously, there is a history of prostate. We know that they are taking medicine for that. But I still feel okay, I'm a little experienced, should not be a problem. I'll get away with it. Now, the problem here, remember, if you have a small pupil and a rhexis and a soft cataract, it may go into a plate. If it goes into a plate, then you are in trouble because then you can't go to the periphery, you can't see, etc. So that care you have to take that it doesn't go. So I'm always having a fear, will it go into a plate, will it go into a plate, but that care you have to take. So now as you see that I'm going nearer and nearer, the iris is trying to come out, which is okay. You can again use viscoat properly to dilate the pupil and make sure that it remains dilated. But I'm going ahead, there is really nothing much to worry at this stage. And now I'm trying to hold the nucleus, okay, trying to get a grip and trying to bring it out. See that? But what happens is another thing. If you have a soft cataract, try to use a blunt tip. This is for someone. If you have a brand new tip, when you have a vacuum, the vacuum itself will go through the nucleus and suck it out and release the nucleus back into the bag. So that's another care. So of course, if you have a very hard cataract, you use a brand new tip. If you have a soft cataract, you should use a blunt tip or an old tip. Preferably do that. And now I'm going here, everything is fine. I'm going to show you one step that causes a little issue. So you see that, yeah. So now I'm in that area there. Now once if you hold the iris, okay, in such a scenario, now you can see the shape of the iris. Now this is going to be a headache throughout your procedure. So whatever you try, so I'm trying to push it with my chopper, the more you touch it, the more it gets irritated, which we know. And I'm trying still and think I'm okay, I'm still a little more experienced, I should be able to get away with it, should not be a problem. But always remember, believe in your instinct. So if you know sometimes when you go in the morning in the OT, you feel that nahi aaj kuch to gadbad hoga, make sure you are alert. And believe in your instinct, don't overrule it, and make sure you then make sure that the patient's eye is, of course, the top priority. So here you can see I'm still trying. I thought I'll get away with it, and you can see how the shape of the iris has changed. Now I think, no, I can still manage. There's no harm, so I'm again putting viscoat, pushing the iris away, and it does help many times. That you can form the anterior chamber well, it will be deep, and you can still get away with it. But so I'm putting it, again putting viscoat and methyl in the center, viscoat all around, and trying again, okay? Now you will keep trying, and it keeps happening, but now it's getting into a plate. And again the pupil has come down. So over time this happens. So now what are your options, right? Because you still have a little plate. This is not going to work, believe me. So then I decide that we can go ahead and put either hooks or a ring. Some of you might not know, but there is a ring called an omega ring. Have you heard of this? I don't know. So it's made by our Concordia. So I'll show that little video. So here I go ahead, and then I said, no, this enough is enough. You can see the pupil is still coming down. The iris is trying to come out of the side port. Iris is trying to come out of the main incision, although it's well created. And now the pupil is further small. So now I decide that I'm going to go ahead and put in a Malugan ring. Now remember, when you want to put a Malugan ring, when there is already a CCC, the scroll itself can capture the iris and the CCC. So you have to be a little careful. So I'm going ahead, doing this, putting in the first Malugan. So I got all the 3 scrolls in one shot in the insertion. And then you can take a Krugner's hook, right? This is a Krugner's hook. It's got a little ball on the tip. That works better than either a Sinskey hook or a T, because it actually holds on to the scroll of the Malugan ring. You can use whatever you have access to, but in my hands, the ring has been working beautifully. And so just go ahead, do your phaco. Now it makes it much easier. Do your phacoemulsification, remove the nucleus. Now you can see this scroll, okay, has got the CCC with it, right? So you can't see the margin. Now IA is still remaining. So then you disengage, and then you bring it little up, and then push it, and then you can see the margin of the CCC. So this is one way of doing it, but preferably before you do your IA, preferably make sure that your CCC is visualized all over quite well, and then go ahead. Now I thought the bag was a little weak, so I went ahead and put an endocapsular ring. You can see the endocapsular ring, and I like this technique of insertion, that you hold a T in the dominant hand and a Sinskey hook in your non-dominant hand. So you can see that there is a T in this and the Sinskey hook here. But remember, when you're doing this together, sometimes you have to be careful. The Malugan ring can also get dislodged and go behind. So you have to be careful at that stage. So here you can see the T itself is holding, and then just turn your hand a little bit. If you turn your hand, the endocapsular ring will very easily just go into the bag. Go ahead and put in your lens, and see when I remove the Malugan ring, see how the pupil becomes. So this would never have been easier. It was wiser and safer for us to go ahead, and I'll just show one more video of the omega ring, because some of you might not have seen this. So this was a thing I just want to show you. This was the first attempt of mine on the ring. So this is the omega ring, and it's damn easy to use. And best part is it's made of the silicone sleeve of our phaco. So it's etioable and autoclavable. Okay, so you can see these 4 holes which are there, and this patch goes below the iris. So I'm just showing this, and we'll see. You need a larger incision. I've not tried it through a small incision, but now it's gone in. Now you can just see how easy it is to just hold on to the iris. So that goes below the iris, and then just put it. So this is called the Omega ring. It's worth $3,000. I have no financial interest. I don't think he also has any financial interest. Go ahead and just put it. So this is, I think, another great ring innovation from India itself. And this stays like this. It looks quite thick and bulky, but it's very easy. This ACD was quite less. It was about 2.8 or rather 2.5 and 2.5, no? 2.2. And I still went ahead and I could place the Omega ring quite well. So point here is it stays quite well. If you want to see throughout the procedure, does it maintain position? Answer is yes. Does it move throughout your bimanual? Answer is no. And it can hold on to your iris. Go ahead and put in your lens. Once the lens is placed, again dislodge it and then dislodge it and just bring it out. So it just comes out through your main incision. My main incision is 2.4, so it's okay. So this is just for some of you who had not seen it before. Thank you, Dr. Shivani, for this opportunity. Thank you.
Coming up next, I would like to introduce Dr. Vardhaman Kankaria, sir. He is internationally recognized refractive surgeon, cataract specialist in Pune. He is the founder and director of Asian Eye Hospital. He is well known for his expertise in LASIK, SMILE, ICL, keratoconus, and management. And he has a record for the entry of LASIK surgeries. And he has authored 50 plus international research papers. Till date, he is very active in all our scientific committee scientific committee meetings, and has shown great academic interest even in pushing youngsters for, and including me, inspiring all of us since the time of PG. I've done my PG in Pune, and I've seen him since day one, and it's definitely an inspiration till date. Thank you, sir. Congratulations for winning the elections.
Thank you so much, Dr. Shivani, for including me in your IC. Um, friends, we are talking about some of the interesting scenarios, and I think all of us have seen post-RK patients. So I'm going to show you one such case. So this is a 34-year-old female who had the history of RK done when she herself was a pediatric patient. So she was that time 20. So this 25 years back, she underwent RK when she was herself 11-year-old, and so basically she lost one eye to trauma, and there was history of also steroid use, so she also developed early cataracts. So when we saw she had a grade 3 to 4 brown cataract, she had 16 incision RKs going from, as you can see, one eye was NPL, the other eye was finger counting. And if you look at the RK incisions, they had gone right from almost absolutely the center of the visual axis, still almost going beyond the limbus, having a lot of scarring. So, of course, as we know that the RK causes a tremendous amount of flattening, and that is what we see, a lot of irregular astigmatism as well. And when we looked at the IL master, you can see the axial length was almost 32 millimeters. The IL master showed readings of about 13 diopters, and when we looked at the SCRS calculations, it showed varying degrees between 14 to almost 15.5 diopters. So we all know that ALPAR calculations in patients who have undergone previous corneal procedures, including the laser corneal refractive surgery, have actually very inaccurate IL calculations. And to understand what happens with them, let's understand how the Virgin Eye formula works. So in the Virgin Eyes, the formulas are categorized into theoretical formulas or regression formulas. Regression formula is on the accumulated data, and the theoretical formula works on the principle of what is called as the ELP. ELP is the effective lens position between the anterior refractive surface of the cornea till the nodal point of the lens, that or crystalline lens, or the lens that we are going to implant. This ELP prediction relies heavily on your keratometry, and that's the main reason that there is a lot of irregularity, a lot of erroneous outcomes of your biometry. And when we looked at all these sources of errors, this is going to be because of three primary errors, including your index of refraction error, the measurement error, that is your instrument error, and the formula error. So when we look at the keratometry reading of such patients, we always rely on the index of refraction formula, which presumes the anterior versus the posterior curvature to be in the ratio of 1.20, 1.21. But when somebody has undergone a myopic LASIK, your cornea becomes actually flatter. So there is an overestimation of keratometry and underestimation of your IL power. And the opposite thing happens in the hyperopic eyes. At the same time, for patients who undergo these procedures, as we all know, when we calculate through topography, the calculation should be done actually in the center of the cornea, but it is actually done at 3.2 millimeters away, thus giving to second error. And the third one is, of course, the formula error, because as we all have seen, the ELP prediction depends on keratometry heavily. And because of this, again, there is a underestimation of ALP in myopic LASIK or RK patients, and there is a significant overestimation of underestimation of your IL power as well. But what also happens with the RK patients is that along with these three errors, the RK also has the fourth error, which is called as the corneal instability error. So let's look at the surgery. So basically, as you can see, there are a lot of incisions. So we have gone through the side port between these two incisions on both almost 10 o'clock and 2 o'clock position. I like to stain in such challenging cases. We wanted to have a slightly larger rhexis. So as you can see, we are making a rhexis which is beyond 6 millimeters. Especially because the cataract grade is also 3 to 4, and we don't want to actually have a lot of excessive maneuvering. Therefore, now we have gone for a rhexis, and as you can see, now once the rhexis is completed, you have incision which is scleral. So that is another thing that all of us should know, that it is better to go for the scleral incisions rather than going for the corneal incisions and be away from this. So once hydro was done, actually the nucleus popped up, but which was still okay because we had a very deep anterior chamber. So we went ahead and did the chopping in the anterior chamber itself, and went ahead and engulfed all the nuclear pieces one by one under viscoat cover. And once all this nucleus was removed, as you can see, you have to be also very careful in these patients because they also have a lot of temlucent movements of the iris, and can also showcase almost like a reverse pupillary block and the lens iris diaphragm syndrome. So as you can see, I'm removing the last bit of this cases. It is important that you refill the chamber time and again. And once all the pieces are removed, of course, you go ahead and you do the IA in your regular fashion. But what is most important in this case is, one thing is, of course, the challenge of removing the cataract in eyes who have so many incisions, but the second one is, of course, the biometry. As we did discuss, the biometry is in this case is calculated with the ESCRS formula, but shows still a lot of errors, especially in RK patients. So this is a thing that we have been using for last few years. This is called as Maloney's method, in which we use the intraoperative retinoscopy, and that is calculated and multiplied by 1.7. So this, in this case, gave the IL power of 21 diopters instead of 15 diopters. So once we saw that, we actually got the patient back. So sometimes we also do this retinoscopy on the first day of the surgery by doing retinoscopy in the OPD as well. And then once you know which IL power to implant, this is the IL that we are implanting now. And once this is done, of course, remove all the viscoelastic once again and close the incisions. And this patient did very well with hardly 0.75 diopters and 6/9 part vision, as we have seen. Now we have, I think, series of 65 eyes which were done by this approach, and more than 90% of the patients are within 1 diopter, which is quite a good accuracy for the biometry for anyone who has more than 12 incisions. Thank you very much for your kind attention. Thank you.
Thank you, sir, for such an insightful talk. I would like to introduce our next speaker, Dr. Harshul Tak, sir. Congratulations, sir, on winning the elections, firstly. Sir is widely known in ophthalmology for coining the term hydroimplantation. We also use his hydrodissection cannulas regularly in our OT. He has been a driving force in the scientific committee. He has been a driving force in professional as well as personal achievements, here including a gold medal at the Rajasthan Ophthalmological Society. He continues to inspire all of us to even work beyond ophthalmology and have a life beyond that. So he is somebody who respects work-life balance as well. I would like to introduce him to please tell us what was his challenging case in the OR and how did he navigate through it. Thank you, sir.
Thank you so much, Dr. Shivani, for including me in your course. And so, this was a case which had a traumatic subluxation, and as you can see here, the another big problem was the fibrotic anterior capsule which was there in this case. So the principle we need to follow is to always cut through fibrotic areas, don't try to pull through fibrotic areas. And whenever there is clear area in between, you can use your microcapsular access forceps. And always try to make 1 or 2 extra paracentesis incisions for these micro instruments, because you need to work bimanually and go through various angles to cut through this fibrotic capsule. So you'll realize here that I'm again changing my hands and trying to make a capsular access. Once we reach in the area of subluxation, we need to take care that we have a good rim of 2 millimeter there, so that when we are using capsular tension segment, it doesn't slip out of the capsular bag. So once the capsular access is complete, again I go ahead and replenish viscoat there in the area of subluxation, so that there is no vitreous antivitreous phase disturbance. And it's important that you stabilize the capsular bag with capsular hooks first, because it's very important while you are doing chopping, so that there is no further subluxation of the lens. And once you put these capsular hooks number depends on the area of subluxation. If it's 2 to 3 clock hours, you don't need support many times, but if it's larger than that, depending on area, you may use 2, 3 or 4 maybe capsular hooks. So capsular hooks are ideal for the subluxation, but if capsular hooks are not there by chance, you can also use iris hooks to stabilize it. So once you stabilize capsular bag, it gives anterior-posterior support. This was a traumatic cataract, so cataract was not that hard, it was brittle cataract. So still you try that you don't cause collapse of anterior chamber, because any collapse may cause vitreous disturbance and vitreous loss or anything like that. So always try to maintain closed chamber while you are doing phaco. So do visco exchange before coming out. So these are the last nuclear pieces which are being emulsified, and after that, before taking out my phaco probe, I go ahead and use viscoelastic cannula. So you'll realize that the capsular hooks, they tend to come off because now bag has become empty. So maintain closed chamber, come out. Depending on the severity of subluxation, you may decide to put CTR before taking off the hooks. But here it was a traumatic subluxation and the rest of zonules were intact, so I just take them out because CTR may get entrapped there in the capsular hook segments. So it's better if you can take them out. So once I take this out, then there's a time for CTR ring to go in. So CTR goes in, and this CTR is essential to give equatorial expansion of capsular bag, so always use Kugel's hook from side port to give direction, and once it's inside, you realize that it's got equatorial expansion, and then you can meticulously clean the cortical matter which is there. And once you clean the capsular bag, now it's time for long-term fixation of this bag. For that, either you can use Hoffman pocket or you can make a scleral groove 1.5 millimeter behind limbus. So this is just irrigation aspiration. So this is the capsular tension segment. We all know it's made of PMMA. It has a wing and an eyelet which pops out above the anterior capsular access margin. So this is a 90 proline which I previously was using in cases to fix CTS, but now I use 60 proline to flange them. So two arms of the suture are tied here and it's put in the capsular bag. Care should be taken that the eyelet remains above anterior capsular access margin. And once you put it in, just pass 26 gauge needle and railroad both the needle of this 90 proline suture out of this clay groove. So once both the arms are needle are out, then you can tie a knot there and titrate the tension which is needed to stabilize this bag. So this either you can use a Cioni CTR or CTR plus CTS segment, which is easier to use than Cioni CTR. And you then, depending on the pathology, this was a traumatic subluxation, so I decided to put single piece IOL in capsular bag and then hydrostitch all the wounds. And if it's a progressive zonulopathy, you should put a 3-piece IOL in place of single piece IOL. So that finishes the case. Thank you very much, Shivani, for giving this wonderful opportunity.
But the shoes are trademark.
No, sir, go green for glaucoma, sir.
Till the shoes.
Unfortunately, hope I'm audible. Unfortunately, it's a green, pink, red for this.
For this. Lovely, lovely. You
Okay.
continue to inspire us all, sir.
Thank you, thank you.
So, Dr. Prasanna Ramesh, he needs no introduction. He is the research director and glaucoma head at Mahatma Eye Hospital, but he doesn't limit himself to glaucoma. He has dabbled in all possible fields, including including his innovations, and we have all seen his 3D models, his augmented reality innovations that he has been showing us at every conference, and it just keeps getting better. I would like to see today which innovation has he done in the OT which is going to inspire us all. Thank you for coming, sir.
Thank you, Shivani. Thank you, Kumar sir, for always taking me along with you. Every year we have this photography session, but let's see what we do this year. And I would just like to highlight 3-4 cases which actually made me or took me where I am today. This is one of my favorite techniques, or the case which happened for me when I was just going ahead doing a capsular excess and the hydrodissection, and the lens was looking good in the bag, and when the stop and chop technique was initiated and the rotation of nucleus difficulty was noted, there was something that was slightly offset, and I was able to appreciate that there was a flutter in this particular area, and the nucleus started to wobble, and it was a very, very dense cataract, a toric IOL patient. So these were the things that were dealing in mind, how to go about the bulky nucleus and the zonular laxicity, and I was into MIGS at that point in time. Suture GAT was one surgery that I used to do. I was just thinking, can I do something with a suture? So it's one of my cases 3 years back, and the patient is on good follow-up. Starting by first putting the hooks and stabilizing the bag, and going ahead with the nucleus phacoemulsification with a bimanual cortical aspiration, everything being done in slow motion, and then trying to settle the bag as much as possible. And the zonular dialysis was definitely bigger than anticipated. CTR alone did not suffice, and the CTR was placed. CTR 11, and the bag was tried to be stabilized as much as possible, and the vitreous disturbance was also taken care of by a vitrectomy in this particular area, the 5 clock hours, and the implanting CT segment was contemplated with the Prolin suture. The 26 gauge needle was actually injected 1.5 millimeters posterior to the limbus, and the common mistakes or scenarios that can happen is I went behind the PC and I actually touched the PC. So again, for the recording and for the benefit of the members who's going to watch it in the future, you can see these are things you should avoid. You can see I'm almost going and touching the PC, and it even caused a wrinkle. To my luck, the PC did not open at that point in time. I did keep the suture in the AC, and I thought if you are not correct in your oriented plane, it's not good. So the needle was withdrawn, and then I used hyperviscous fluid, created a barrier or a chamber between the posterior iris and the anterior lens capsule to create the space in the ciliary sulcus, and then again rethreaded with the iris spatula as a guard so that I don't make the same mistake again. The suture was passed into the lumen and exteriorized. Then the CTS was passed, and then the mushroom tip that we fondly call in suture gad, now it's the flange technique, so was then injected. The CTS segment was then injected inside, lodged, and then the toric IOL was placed, and then the CTS was adjusted on the outer side of the suture, trimmed accordingly, such a way that the bag is in center, as well as we get the suture also buried in the intrastromal tract. So this patient is having a 3-year follow-up, doing very good, and I did publish this technique few years back. In 2022, 2023 we did this. Another personalized technique of mine, the donut capsular axis, which works well in my hands. So the centrifugal force that we see in hypermature cataracts here, so this is my Indian Journal of Ophthalmology video, which I am just sharing. The hypermature cataract has an intralenticular pressure, which we all know, and it's well documented. And the Argentinian flag sign happens. So what I tend to do is a 3 millimeter axis followed by a 5 millimeter axis, which is one of the many modifications that are available in the market, or many different surgeons are even much better ideas, but this just works better in my hands. So 3 millimeter axis with the cystitome or with the forceps, then debulking the chamber with the IA probe. And now what do I do is, I don't connect like this. I just put a nick and go centrifugally. So that is the trick here. Put a nick, go centrifugally, automatically the nick will get connected with the circular axis, but start from here, go like this, and then that's it. We'll be able to just take a forceps or even with a cystitome. Donut rexus, even in a small pupil with hypermature cataracts, making a as small rexus as possible, even sub 3 millimeter, and then debulking it with the irrigation or the aspiration probe very gently, and then again centrifugally 1 or 2 millimeters away, centrifugal cut, maybe slightly tangential, not fully radial, somewhere between a radial one and a tangential one, and then completing it with a simple cystitome also works well without any running away effect. We got it out in an Indian Journal of Ophthalmology 2024. And then this was another one, one of my residents at Mahatma. So started the rexus and it went like this with a Y kind of a sign. You can see why this happened was initial movements, I felt they just put the nick, then another nick, and it started deviating in an Y-shaped manner. And also to add on to it, the cystitome was taken out. These were cases which made me a better person, and there was actually a leak, or rather you can see the side port itself was disengaged. So this was left on my plate to manage, and I'll cut the anime. So first secured the side port. Once the side port was secured, started with phaco still. I didn't want to abort it. I just thought, let me see. Nucleus was not a very bulky nucleus in this case. I was always having an eye on the 3 flaps or the 3 triangular flaps. It was more of a not a in the bag phaco I would say fully, but a supra bag, maybe slightly in the sulcus as well, but all's well ends well. After this was done, a small gentle IA keeping in mind, and this was the inverted Y-shaped Argentinian flag that was still remaining, which I had to always keep in my mind. And then using the microrexus forceps did this particular cut. Then after that you can see some more IA, gentle IA. Now using the microrhexis forceps, using the microrhexis forceps, putting a cut on the, putting a cut on that side, that is this plane, and then finally using the microrhexis forceps and doing a cut on this plane. So small cuts, trying to create as much circularity as possible, and at the end it looked like this. You can see that there is one radial tear here, one radial tear here, and one radial tear here, and another anchoring suture to secure the wound, and then a 3-piece IOL in the sulcus. Or did try to do max to place it in the back, but I think it was in the sulcus, and the patient did well even now currently under 3 to 4 year of follow-up. I think these are just 3 cases which I wanted to show. I did have one, but want of time, I think navigating through the tough cases, I think these are 3 cases and few more which I have in my YouTube as well, which has definitely helped me become a better surgeon with better ideas. And currently we are working with more on MIGS implants, which we will be soon coming up next year maybe. We are trying to bring out our own MIGS implantation. And thank you, sir, and thank you, Shivani, for the opportunity and taking me along with you. Thank you.
So, thank you, Prasanna sir, for this enlightening talk. The theme of this talk or this presentation, this instruction course, is to incite that you have to think about your processes before you get into the surgery. It's important to understand that there is a very thin line between deciding to perform the surgery, thinking about your steps, and finally getting an outcome. So I want to be in that picture too later. later. So no, it's okay. Okay, I trust you. So this particular video that we have made is a testament to the tough surgeries that we get and what outcome we are getting out of it. Why it is important to discuss these cases? Because for these surgeries, everybody will have a plan, but the master plan comes when you get the outcome and you finally thought that, okay, this is the case, that this is my master plan. If I get a similar case like this is what I should do. So learning from your own cases is also as important as learning from anyone else's. And we face this every day in the OR with the simplest of the cases, be it a myotic pupil or a large incision or simply a rhexis runaway that can cascade into something worse if we have not learned from our own cases. So this is a collection of cases that we have made into a very, the screen. It's a collection of cases that we have compiled into a video, and yeah, please enjoy. There's no audio. It's connected, no? करूं? क्या हुआ? Dr. Bond, we have a situation and a few challenging cases, and we need you to come in immediately. Vacation's over, Dr. Bond. There are a couple of challenging cases, and I need you to step up.
Trouble never takes a vacation, Dr. M. What's the case?
It's a bad case with the IOL in the vitreous. Extracting it will be like disarming a bomb. One wrong move and the eye's lost. What's your plan?
Sounds like a typical Tuesday, Dr. M. Let's get to work.
Dislocated IOL in vitreous, no documentation, IOL design unknown.
Options: explant the IOL and glue another one or a posterior iris clip. Flaps are made through 2 side port incision started the anterior vitrectomy. To our surprise, the lens came up held with the micro-grasping forceps and brought into the AC. This is a non-foldable 6.5 mm optic IOL with dialing holes and a 10-degree angulation. Notice the orientation of the haptics. To correct the orientation of the IOL, we flip the IOL in the AC. This is a rigid optic with large J haptics which are extremely brittle. Since we have the right orientation, the same IOL can then be carefully externalized and the haptics can be glued in position.
Let the lens fall. When it crumbles, we will face it all. Flip, refit together and stand tall.
In conclusion, with 2 minimal port vitrectomy, it is possible to flip the same IOL and refit the same for brilliant visual outcome.
Your next case, Dr. Bond, is a twister. A patient with previous penetrating keratoplasty now has cataract. It's a delicate procedure, wouldn't you agree?
Well, Dr. M, this just feels like my martini. Quite shaken, but I'm not.
Don't get cocky on your own cocktail, Dr. Bond.
A patient had penetrating keratoplasty with posterior synechia with high astigmatism and advanced cataract.
The topo shows 15 diopters of astigmatism, toric marking done, and a scleral incision made. With dispersive viscoelastic, breaking the posterior synechia with the Besset's Y to be able to place the ring to enlarge the pupil. With the rhexis forceps, the rhexis is completed. Followed by hydrodissection and a safe in-the-bag phacoemulsification. Under dispersive viscoelastic and BSS plus, and in-the-bag chopping all around to make small pieces to make sure that it's an in-the-bag phacoemulsification. Followed by loading the smart toric 14 diopter IOL in the injector and placing it into the bag.
Hey, a simple surgery is not enough. We need a toric lens that's safe and small. My love, ring for pupil to widen up. Together we can fix the cataract. My love.
Master plan to use a dispersive viscoelastic ring and a smart toric IOL. I always wondered, Dr. M, what lies inside this trunk?
This reminds me of Moneypenny's Pandora's box. Do you recall, Bond?
What's this, Moneypenny?
Dr. Bond, this is a very close friend of mine. Her name's Pandora. And the vision is completely clouded by this membrane that she has. God knows what's lying underneath. Can you help me?
Oh, this sounds like a very easy challenge for me. We shall toast to this after the job is well done.
Don't push your luck, Bond. You're jumping the gun.
Gun? What gun? Check out my Phaco Pro PPK.
A case with persistent pupillary membrane with a complicated cataract. Patient underwent slit lamp examination and a UBM which shows area of absent zonules.
With micro scissors and micro forceps, remove the persistent pupillary membrane. Checking area for absent zonules. Followed by flax to perform CCC and lens fragmentation. Create the Hoffman's pocket. Enlarge the CCC, place capsular hooks, and perform a bimanual IA for soft nuclear and cortical aspiration. Place the Sionis ring in the bag. With a railroad technique, secure the ring in place. Place IOL in the bag in the same direction to support the subluxation. View the pre-op and post-op pictures.
The view through a membrane opened, a dangling cataract at play. An eye surgeon that's second to none, Sionis will guide the way.
It's time to get serious, Bond. This is quite a case. One of our agents has an iris clip IOL in situ. It's a phakic IOL, and now he has a cataract as well. What are you going to do about it?
I have a trick up my sleeve, Dr. M. Just wait and watch.
Enough with your quips, Bond. This is your last case, and then you can go back to your vacation. Patient operated 30 years back. Non-foldable iris clip phakic IOL develops a cataract.
One option, explant the phakic IOL, take a suture and create another wound. A completely new approach is to perform CCC under the phakic lens in place. Followed by hydrodissection and phacoemulsification in the bag. Followed by bimanual IA under the iris clip IOL. To remove the cortical matter, followed by replacing the IOL and suture in place to prevent astigmatism. This is followed by disengaging the iris clip IOL and replacing it by another IOL.
Under the clip, the fake goes done with precision. Iris good as new. Are you willing to try? Steady hands, balance remains. You know my name.
An innovative approach to cataract removal under phakic IOL, followed by IOL exchange and suturing to prevent astigmatism.
Congratulations, Dr. Bond. You've restored more than just vision today at His Majesty's Vision Services.
Turning complex cases into simple procedures, that's what I'm here for, Dr. M.
Thank you, thank you, thank you. Thank you, everybody. I would like to introduce my next speaker. Welcome, Dr. Sumer Doctor. He has completed his advanced subspecialty fellowship in oculoplasty in LV Prasad Eye Institute, where he served as Chief Clinical Fellow. He has performed over 1,000 plastic procedures ranging from aesthetic surgery to functional eyelid construction and orbit and thyroid eye surgery disease compressions. He has multiple index publications to his credit and serves a leadership role in India as well as representative on the Young APSOPRS Executive Council. Welcome, sir. Welcome, Sumer. And I'm looking forward to what you contribute to the cataract part of it.
Thank you so much. Thank you, Shivani, for this opportunity, and AIOS as well. That was an outstanding presentation to follow. So what I'm going to speak of is the whitewash paradox. That's the topic given to me. We're going to speak about how to manage white cataracts. These are cases, surgeries that I've performed in my fellowship itself. So I cannot match Shivani and Dr. Kumar's quality of video production, but I'll do my best. A quick review, we've all operated mature cataracts, and that becomes a high burden in rural setups, which is where I was at LV Prasad for a while. We'll begin with how we should evaluate these. So a good slit lamp examination, making sure that we are not missing out any obvious subluxations, and very importantly to look for fluid pockets on dilating the pupil, because a lot of times fluid pockets do lie in the periphery and not in the center, and that gives you the ability to have a very nice preoperative plan before we actually go ahead with surgery. The most important parameter when we are dealing with white cataracts for any kind of surgery, may it be phaco or manual small incision surgery, is all about decompressing the bag and making sure that we maintain chamber dynamics when we are performing our CCC. So this is our first video. I have made a small cruciate incision with a 26 gauge needle, with which I am now going to get an entry point into our bag and going to start decompressing. So as we can see, that we have some egress of fluid already coming out, which gives me a good indication that we are dealing with a cataract with some fluid pockets, which I can decompress prior to any next step that I perform. I have taken a 27 gauge cannula, and now I am decompressing the periphery. What's important to note here, and the reason I've put this video up, is because the direction to go in should be perpendicular to the equator of the lens, and we should go almost till the mid periphery or even the periphery when there are fluid clefts, so that we make sure that we convincingly get the bag decompressed. The main reason for doing this is to maintain the dynamics of the anterior chamber. Overfilling the anterior chamber is never always the answer. Decompressing the bag itself and combining that with a good aliquot of viscoelastic does give us a very good stable base to perform our rexes. I'm performing these with a micro rexis forceps. I've already made my main incision, but this can be done without a main incision as well. So once again, just making sure that I'm going tangentially and keeping my rexis on the smaller side. In younger patients with white cataracts, when we have a smaller rexis, it is a safer one to perform because the anterior capsule is more elastic. Of course, it goes without saying that we have to stain these capsules. We get more traction, and the capsule behaves more to the surgeon's commands when we are actually staining it. Like I said, controlled rexis performed even if it's slow gives us a very good opportunity to have a very quick phaco post the rexis. Here I'm using my second instrument in my left hand to flatten the capsule at all times. This is an option so that I can hold the 2/3, 1/3 junction and have a very good control over my rexis at the end of the procedure. So once I close this rexis, I have a pretty well centered 5.5 millimeter rexis through which I can perform a safe phaco. So the next video is once again a mature cataract with fluid clefts where I have again decompressed the bag in a similar manner. And here what I'm going to do is I'm going to perform a slightly smaller rexis, which is a mini rexis, which I will extend in the next step. So this mini rexis, which is a small circular punch hole opening, will give me a complete circular rexis, which makes things easy for me later to decompress, and there is no radial cuts or any areas of tension through which this bag can be compromised. So what I'm doing here is quite important. I'm taking a visco cannula and I'm decompressing the periphery fluid clefts, which is allowing those small clefts which I might have missed out to come into the center and make things easier for me when I perform the rest of my capsular rexis. I've just taken a micro scissor and I have made a small incision, which I'm now going to use to extend my rexis to the size that I desire. So once again, since the bag is decompressed, my life becomes easy, and now I can safely perform this rexis with no fear that this is going to radialize in any way. The second hand actually comes in good use because it helps me to flatten the rexis at all times, and that makes things much more comfortable for me. So that's a good technique to employ in these cases. So once again, a good rexis with which I've performed a very easy, safe phaco. Honestly, the phaco is the easy part of these cataracts because they're very soft. They're easy to chop and eat up quite quickly. So that once the rexis is secured, things are easy. An important point to note here is that these bags have been swollen up for a long time, and they can tend to be quite floppy. So once the nucleus, which is the main chunk forming the AC, is out, it can be that the posterior capsule might be a bit floppy. We need to be careful with our fluidics and make sure that we are performing a safe irrigation and aspiration. So this video is just a short clip to show us that when we have a smaller rexis, it can be tangentially cut in any position we desire if we are comfortable in the left and the right hand, so we can just get it to the adequate size with a micro rexis forceps. So here I've done it with, I've made a cut with the micro scissor and I'm just extending the rexis, and I'll do the same with my left hand, so there I get an adequate size on the other side as well. Once again, a well-maintained rexis, so we have an easy next step of surgery. Sometimes we may end up with cases where we might suspect that. Ye pause. Oh, yeah. Yeah, so this video was just basically showing us that there are some cataracts which may seem like they have fluid pockets, but they really don't, and these become really safe for us even without decompressing the bag. It's moving. Lag हुआ है. ये lag हुआ है, एक second. A very long one. क्या करें? बंद कर दूं? Okay. Just give me a second. Am I the last one? Who's left? Oh, then we're done? Okay, okay. Okay. What's the next I see here? Screen is frozen. That's fine. I wanted to show Kumar's Rexis forceps after. No, no, it's not. It's the laptop. Leave it. Okay, thank you everyone. Thank you.